Hi, good afternoon, everybody. For those of you who don't know me, my name is Drew Keys, and I'm the Western Pacific Program Manager for IAPB, the International Agency for the Prevention of Blindness. Welcome to this afternoon's Focus on Glaucoma webinar in the Western Pacific. For those of you who are attending an IAPB webinar for the first time, you may not be familiar with IAPB. IAPB is the global peak body in eye health. We have over 160 members made up of NGOs and corporates, of eye hospitals and universities. And we quite often do events like Focus on Glaucoma. One of our key pillars is around the dissemination of knowledge. So events like today are very, very important to us. Of course, Focus on Glaucoma comes to you during this World Glaucoma Week, the 8th to the 14th of March 2020. We are partnering with international organisations and experts in glaucoma care to draw a spotlight on the third leading cause of blindness. Focus on Glaucoma marks the week with a series of activities. We have lectures, we have webinars like this one, we have blog posts, and we have Twitter advertisements, we have social events. It's really, really a very big week for us. We run the initiative together with our partners at Allergan, at the International Centre for Eye Health, and the World Glaucoma Association. Really looking forward to spending some time with you this afternoon. We have a really great group of panelists, and I hope you'll agree with me that they come from a diverse number of backgrounds. We have with us Associate Professor Heather Connor, we have Dr. Bernardo Suarez, and we have Ms. Lauren Entwistle. To give a proper introduction to each of these people as we lead into the presentations, I'm going to hand over to our chair for this afternoon, Dr. May Ho. May is an optometry and primary care advisor at the Fred Hollows Foundation, where she's working on the integration and implementation of its refractive errors strategy. May has worked on the development of sustainable eye care programs in various countries all across the Asia Pacific. So of course, many of you will know her from her work in this region, and also in the Caribbean region. In her previous employment, together with in-country partners, she developed the first optometry education program in Vietnam. So please welcome to take control of this afternoon's session, Dr. May Ho.
Thank you, Drew, for the kind introduction. The aim of our session today is to talk about the different collaborative models of care for glaucoma, working together to fight the sneak thief of sight. Our first speaker is Associate Professor Heather Connor. Heather is an Associate Professor at the School of Medicine at the Deakin University, where she runs the Optometry Placement Program. She also works in the Glaucoma Monitoring Clinic at the Royal Victorian Eye and Ear Hospital and has worked in India and Myanmar in voluntary optometry teaching programs. Her main fields of research are in glaucoma and ocular allergy. Heather will be talking to us about collaborative models of care and her work at the Glaucoma Monitoring Clinic at the Eye and Ear Hospital. Join me in welcoming Heather.
Thanks, May. Sorry, I just had a few technical issues there, but hopefully everybody can hear me now. So I'm going to start by talking about why we need glaucoma collaborative care, and really start by talking about the fact that glaucoma is responsible for almost 3% of low vision and blindness in the world, and is currently the third leading cause of irreversible blindness, as Drew mentioned. We know that the most recent meta-analysis from Tham and co-authors estimated that the total number of people with glaucoma will increase by 74% by 2040. This is mainly going to be due to aging populations, particularly in Africa and Asia, where there will be increased life expectancies. However, the population of older people will also continue to rise in Europe and in North America. And in Australia, the population of people aged 65 years or older is also set to rise. Figures from the Australian Bureau of Statistics show that in 2017, people aged 65 or over comprised 15% of the Australian population. This is projected to rise to between 21% and 23% of the population by 2066, while in this time the overall population is expected to grow to up to 49 million people. And in Australia, as in other countries around the world, the prevalence of glaucoma has been shown to increase with increasing age. This graph shows the increase in glaucoma prevalence from the Melbourne Visual Impairment Project and the Blue Mountains Eye Study. There's a slight difference in how the two studies separated the age groups, but the trend is basically the same for both studies. So why does this matter? We know that glaucoma is more prevalent in older age groups, and that as people age, they are more likely to develop the condition. With all projections showing that the population is growing, and also that older people will make up a larger part of this increasing population, that makes it much more likely that there will be increasing numbers of patients with age-related diseases, such as glaucoma. And that will mean more patients who need to be seen, diagnosed, and then monitored for glaucoma progression. For example, in Australia, the number of outpatient consultations has steadily risen over the last few years. For the 2015 to 2016 reporting period, the Australian Institute of Health and Welfare reported 33.4 million outpatient service events, which then rose to 36.7 million the following year and was 38.9 million in the last available report for 2017-2018. And 33% of these consultations were for patients over 65 years of age. And this likely increase in patient numbers is a problem because there are only a limited number of ophthalmologists in hospital clinics. In 2016, for example, there was an average of 3.7 ophthalmologists per 100,000 population, and this number is not likely to change very much. If we look at some other more numbers, in 2016 there were 919 ophthalmologists registered in Australia, which is a small number compared to the 5,134 optometrists registered to practice in the same year. Optometrists work within the community and are trained to screen and also to treat glaucoma using most of the same equipment that is available in ophthalmology clinics, but patients still need to be seen and the diagnosis confirmed by an ophthalmologist. So additionally, since 1996 in Victoria and then subsequently in other states, optometrists have been able to complete further training, which allows them to prescribe ocular medications. And in 2019, 63.7% of optometrists were endorsed to prescribe. This is significant because part of the training involves achieving competency in techniques such as gonioscopy and OCT interpretation. Optometry practices have access to perimeters, tonometers, most also have a fundus camera, and increasing numbers also have access to OCT. Current training programs require competency in gonioscopy and slit lamp fundoscopy, which places optometrists in a good position to assist with ongoing monitoring of patients for progression. As I said previously, ophthalmologists have always referred to ophthalmology for confirmation of glaucoma diagnosis, but with increasing numbers of patients in hospital glaucoma clinics, optometrists are now being more involved in monitoring low-risk patients for progression. And to help with that, RANSCO has actually produced very clear guidelines for referral, and optometrists use these along with the NHMRC guidelines for glaucoma patients. So then I wanted to move on to talking about the Glaucoma Monitoring Clinic, or EGMON, at the Royal Victorian Eye and Ear Hospital. So there are a number of optometry practices in Australia who have collaborative care arrangements with their local ophthalmologist, but this is a different approach. It's actually within the hospital itself. And for those people who are not in Australia, you may not be aware that optometrists don't normally work within the hospital system in Australia. So EGMON was set up as a multidisciplinary clinic in 2007 to monitor stable chronic glaucoma patients using best practice guidelines from the NHMRC. Patients in this clinic have more advanced disease, which means that despite being relatively stable, they're not suitable to be referred out to community-based optometric care under the current guidelines. So the way this works is that stable glaucoma patients are referred from the main glaucoma clinics and other clinics in the hospital to monitor for glaucoma progression. The current template is for a maximum number of 35 patients per clinic, but this does vary depending on the number of ophthalmologists available. The important thing about this clinic, though, is that the makeup reverses the normal allied health to ophthalmologist ratio for a hospital clinic, and this leads to a reduction in the number of ophthalmologists required to run the clinic. This is the personnel, and each week, the first 30 minutes of the clinic are dedicated to an ongoing teaching and staff training session. Team members take it in turn to present on glaucoma or related topics or on new research in the field. This is an important part of the clinic and ensures that everyone is up to date on current glaucoma management, while also providing a collegiate and supportive environment for staff development. During the clinic, patients are seen initially by either the orthoptist, optometrist, or ophthalmic nurse, and after a complete workup of the patient, the ophthalmologist is then provided with the findings and a suggested management plan before they then make the final clinical decision for the patient. And the workup for each patient will include a thorough history and other tests as indicated by the presentation. First-time patients will undergo a full workup, and that includes pretty much everything that's on here, including imaging. So patients who are returning for frequent regular follow-up will undergo the same examination with visual fields and imaging being performed as required, and generally at least once a year. Gonioscopy is also repeated on patients on indication and at least every 1 to 3 years, depending on the patient presentation, again, as per the NHMRC guidelines. So doing all of this ensures that all the required information is available for the ophthalmologist to make their final decision. And as the information is presented at the end of all these examinations, the ophthalmologist can quickly assess the findings and decide on a suitable management plan, allowing for a greater number of patients to be seen, and also ensuring that all the tests that are needed are actually done on that day. And results from the clinic have been good. In a 2010 survey, 78% of patients responded that the time available to ask questions during the consultation was either excellent or very good, as the setup of the clinic allows more time for the allied health staff to spend with patients. Also, 98% responded that waiting times were excellent or very good. And an internal audit found that 91% of patients had a dilated fundus exam, and also 91% of patients had had a recent gonioscopic examination recorded. And this was an improvement in adherence to preferred practice patterns, including timely repeats of visual fields. The EGMON clinic actually has 1 or 2 practitioners dedicated to performing visual fields each week, which allows for any patient who requires a visual field to be seen on that day. And the success of the original Friday morning clinic has resulted in a second monitoring clinic following a similar model being started with orthoptists only on Tuesday afternoons, and the subsequent development of a similar collaborative care model at the Australian College of Optometry. This model uses strict guidelines for patient selection and again involves the workup of patients by optometrists and orthoptists before evaluation by an ophthalmologist. The development of these schemes have been beneficial to patients by ensuring the adherence to preferred practice and also in having more time to discuss patient concerns. Additionally, it is possible to identify stable patients who are suitable to be referred back to community care, freeing up appointment times for those patients who really need specialist care. The clinic also encourages enhanced communication between orthoptists, optometrists and ophthalmologists, and hopefully will lead to further development of more collaborative care models. Thank you.
Thank you, Heather. Our next speaker in the series is Dr. Bernardo Suarez, who is a Melbourne-based ophthalmologist holding a permanent public position in the glaucoma unit at the Royal Victorian Eye and Ear Hospital and at Monash Hospital. His main interests are in complex glaucoma and cataract surgeries, ophthalmic teaching, and surgical training of future colleagues, as well as community collaborative care. After completing his medical degree both in Brazil and in Portugal and graduating from the Federal University of Minas Gerais, Dr. Suarez underwent ophthalmic training in both Brazil and in Australia. Please join me in welcoming Dr. Suarez, who will talk to us a little bit about the Glaucoma Community Collaborative Care Pilot Program at the Eye and Ear Hospital.
Thank you so much for the kind introduction, May. And thank you, Heather, for the lovely presentation. I do work with Heather on the Glaucoma Monitoring Clinic, which we call EGMON for short. So it's a pleasure to always catch up with her a couple of times a month. So what I'm going to talk about is another form of collaborative care, which is the Glaucoma Community Collaborative Care project. Good. So as Heather said, glaucoma is a big problem. Currently in Australia, it's expected for us to have around 300,000 people living with the disease, and the burden is only worldwide is only expected to increase. Obviously, glaucoma management is quite complex because a lot of things can cause glaucoma. You can increase the pressure in the eye, or you can have glaucoma with normal pressure. Patients that are once diagnosed, they very likely would need ongoing care throughout their lifetimes. So that's a lot of ear clinic visits. They need close follow-up, especially early in the diagnosis. We want to identify those patients that progress rapidly and quickly into a blinding form of the disease, and we do want to separate those who in their lifetime are very unlikely to be visually impaired from glaucoma. So we do need to monitor their progression, and as I said, it comes in various shapes and forms. So collaborative care, as Heather mentioned, it comes essentially from a growth in the demand, just by population-wise, in order to help us prevent critical incidents for our glaucoma patients. When we analyzed within our hospital, the Royal Victorian Pioneer Hospital, which is a quaternary centre of care located in the state of Victoria in Australia. So it's essentially the main hospital within our state for eye and glaucoma care. We've identified that a lot of our patients that were being monitored and supposed to have an appointment within 6 months' time were not making that appointment simply because we couldn't give them one. We were too busy seeing very advanced cases. And those people who were presumably stable and were given a 6-month review, about 45% of those people with overdue appointments had some degree of vision loss. So it was essentially in trying to address this issue and avoid critical incidents that we've created this pilot, which is our third model of collaborative care within the Eye and Ear Hospital. So the model has patient-centered care and has clear guidelines, which are in line with our College of Ophthalmology. I'm going to show the same slide as Heather did with the criteria of referral and re-referral for the optometrists to ophthalmologists. There's an agreed commitment from the patients to patients from the orthoptists, the optometrists, and the ophthalmologists involved to take part in the program. Everyone has defined roles and expectations, and there are channels established so we can have feedback from all the parts involved. So just to give a bit more of a perspective, this is a breakdown of the map of the state of Victoria, which essentially shows whereabouts in absolute numbers our glaucoma service patients are located within the state. So we have on our normal clinics, extended wait times. Patient comes in for, they're told they're going to be waiting for 2 to 4 hours, depending on how many tests they need to do. They come in, they check in with the volunteers and then the clerical staff. They are worked up by the orthoptist before they see the ophthalmologist. Sometimes they have to go to have a visual field done, or to medical imaging to have scans or photographs, or what other tests they need before they see the ophthalmologists. A few of the patients still also need to see a nurse if they're either consented for surgery, or if they have falls risk, or if they're diabetic for a blood sugar check. So that just adds several steps to their visit here. Obviously, that's a burden for the aging population, especially the ones traveling from the countryside all the way to a center of health, maybe if they're stable 2 or 3 times a year to have their eyes checked. So that's quite a health burden. Within the collaborative care models that we've established already in the hospital. Our oldest and one of the most successful ones is the EGM one, which Heather mentioned to you. So those in that clinic were monitoring patients who would have advanced glaucoma. A lot of patients have had surgeries already. They're not quite suitable for care to be done outside of the hospital. And it's one of the most interesting clinics I work in because it's the most multidisciplinary one. And there's a clinic where we have open discussion and we share a lot of information about the patients. The patients, as Heather mentioned, from research that Deborah Gleason did back in 2010, I'm quite happy with the way things are run. More recently, in 2016, we started the GCC, which is the Glaucoma Collaborative Care Clinic at the ACO, which is the Australian College of Optometry. So it's an optometrist-led clinic within the College of Optometry that gets a lot of new referrals to the hospital. A lot of the new referrals are just sent back into the community if they're either glaucoma suspects or ocular hypertension. And we just essentially triage those that actually need hospital assessment. There is always an ophthalmologist present at that clinic for support, but it's optometry-led. And the one that I've been mentioning to you is the G3CP, which is glaucoma, and then 3 Cs, collaborative care, community collaborative care program, which are for people that have been within our hospital system and have either early or advanced glaucoma. Sorry, early or moderate glaucoma. So we share the care of those patients with selected optometrists. And I'll talk a little bit about how we actually selected the optometrists who were involved. Again, you can see there's a map of Victoria, and it's in a close-up of the metropolitan regions, where we have optometry practices located. So we have both rural and metro locations within the state. There is ongoing exchange of information between the optometrist that's assigned to a specific patient and the ophthalmologist at the INU. So the patient is still essentially belongs to the hospital, but is followed up locally. That reduces travel costs for the patient. Sometimes if they have to, our hospital here is located in a very central area where parking is hard to find. Some patients have trouble, with taking public transport or actually coming into the clinics. They end up, saving some money by not paying for parking or transport when they're seen locally by their local optoms. They also end up seeing the same person. When they come to the hospital, they might end up seeing a different doctor every time. So it does help build a relationship, which we know can increase compliance with the treatment and medication. We also offer within this model of collaborative care, we do 3 annual meetings, which involve talks from invited speakers. We also have educational sessions. We have work groups where we do case discussions in a small group setting. So groups of 4 or 5 optometrists and 1 ophthalmologist. We have a bit more of an open discussion about selected cases. And it's an opportunity for people to bring, issues or concerns that they have with the program or with a specific patient. So it's a setting of open discussion on top of the ongoing care and exchange of information that we do it on a 1-by-1 case basis. So as Heather mentioned, the principle, which is the Royal Australian and New Zealand College of Ophthalmology referral pathway for glaucoma management, it has clear guidelines, and essentially, if we were to split those types of glaucomas into glaucoma suspects or ocular hypertensions, we would probably follow them up, would send them to the Australian College of Optometry Clinic, and they would go back to their primary referrers and they would be looked after within the community. And those patients that actually have established diagnosis of glaucoma are eligible then to be seen in the hospital. And once we know that they're stable, we share that care with the community. So essentially, say, for example, you get a patient with early glaucoma and you want to monitor and do visual field tests and OCTs and check their pressures every 6 months. They get that done at their local optometrist every 6 months. The hospital gets is informed and gets a report from the optom on how that patient's doing. And the patient only comes to the hospital every 2 or every 3 years. The same thing for moderate glaucoma, but just slightly more often. The patient comes back once every year or every 2 years and is seen by the optometrist every 3 to 4 months or 6 months, depending on the severity of the glaucoma. Those with advanced glaucoma are not suitable for that model of care. They're seen within our own clinics in the hospital, and once they're stable, they go then to EGMON, which is the one that Heather mentioned. So the way we recruited the optometrists for the program, we're looking for the ones that had strong interest in glaucoma in the community. They put forward expressions of interest. They needed to have commitment to teamwork and to collaborative practice and prioritize patient-centered care with a specific interest in public health. Obviously, they had to be involved by APRA, which is our regulatory agency that registers all the health professions within the country. And they needed to have access to the minimal required equipment, which would be a visual field, fundus photos, and a way to check the patient's pressure. A lot of the optometrists, as Heather mentioned, do have OCTs as well. So we started this program in March last year. So this month, it's actually its first anniversary. We're about to have our 4th educational session. So we've had 3 last year, and that's a photo of the team that was involved in the first visit, where we had 2 ophthalmologist talks, a discussion and troubleshooting that we do at every session about specific issues that people are having, or just a broader summary and an audit. We do an ongoing audit of the program. And then we had 3 different other ophthalmologists discussing a case each within the different groups. So the optometrists have a high level of exposure to the different ophthalmologists working within the eye and ear hospital. So in terms of what we accomplished with the program is a triple win. So the optometrists, the patients, and the ophthalmologists win with the program. We reduce waiting times, and we actually, most importantly, reduce the risk of our patients having some sort of irreversible visual loss because they didn't get to their appointment. We create more room to see patients that actually need surgery or any acute episode of care within the hospital system and resources, and we still keep a watch out of the patient. It is cheaper for the patient in terms of travel costs, and it's cheaper for the hospital just by not actually having the patient physically here and just having the chart reviewed as well. So we can allocate resources to the more advanced cases. That was the end of my talk. Thank you very much, me and the committee for inviting me to speak, and I'm sure we'll have some time for questions.
Thank you very much, Dr. Suarez, for that very interesting presentation. Now, our next speaker is Ms. Lauren Entwistle, who is an eye nurse in the outpatient ophthalmology clinic at the Royal Perth Hospital in Western Australia. She's been working with the RPH to develop a new model of care for glaucoma and is about to begin a pilot program equipping nurses to assess glaucoma. She is currently completing a master's in clinical nursing and is a contributor to the upcoming nursing textbook gerontological nursing in Australia and New Zealand. Please welcome Ms. Lauren Entwistle.
Well, thank you so much, May. Thanks so much for having me. It's an honour for me to be here with such inspiring professionals in eye health. So my professional context is a very busy inner city public outpatient clinic, and this concept of collaborative care with regards to glaucoma management is very pertinent to my health service. So for the past 2 years, I've been investigating it and advocating for it. The case for collaborative care within Australia is well established, as Heather has talked about so beautifully. The numbers really speak for themselves. According to 2016 stats from the Department of Health, the average age of currently employed ophthalmologists is 53, and understandably, a good deal intend to leave the workforce in the coming years. So we need to embrace a supported collaborative approach to eye health in general, and glaucoma is a prime area for this. So what can ophthalmic nurses bring to the table? Well, we have a strong foundation in health and medicine. That means we can perform general health assessments as well as ocular assessments. This means we also have aseptic technique and manual handling skills ingrained in us, and we automatically apply these to each patient interaction and procedure. We can also help patients navigate the private and public sectors. Because of our general health backgrounds, nurses can step back and view the patient as a whole person. Many psychosocial issues play into medication non-compliance and appointment absenteeism, which decreases vision, which affects psychosocial issues, which decreases vision in a vicious cycle. Nurses are well placed to spot red flags and be proactive about addressing them. We're trained in basic health promotion principles and have more time than medical staff for patient education. We can also provide information on vision support services to patients and recommend referrals to other specialties. So most ophthalmic nurses in Australia would require training in glaucoma assessment, but I view this as a not a because if you've trained your staff yourself, there's not as much variability between individuals in terms of skill set. You know exactly what they're capable of, and there's a consistency in the quality of training. Last year at my health service, we worked with our service improvement department to do a root cause analysis of the issues in our glaucoma clinic. We are a very high volume clinic, and our glaucoma clinics are very busy and only getting busier. As you can see, in the last 2 years, our referrals have increased by 200%, and most of them are urgent, not non-urgent. Our outpatient clinic is actually the biggest in our hospital and provides over 25,000 appointments per year. Of course, our glaucoma clinics are running concurrently with other clinics, so there's a high demand for the imaging equipment as well. We had a clogged waiting list last year that we were analysing, and there were hundreds of people waiting to get follow-up appointments, but there were also very long wait times in clinic, and sometimes a 4-hour wait was unfortunately not uncommon. We had limited resources last year, and we actually had maybe 1 orthoptist, but then we had about 6 ophthalmic nurses and 2 part-time optometrists. Now, ophthalmic nurses weren't particularly involved in glaucoma assessment beyond visual acuities and the occasional Humphrey visual field test. Because of the nature of glaucoma as a chronic disease requiring lifelong follow-up, we obviously have a very low discharge rate, but we provided 63% more appointments in May 2019 than we did in May 2018. And we were doing all of this without adjusting our staff resources or administrative systems. So out of this root cause analysis, there came a few recommendations, and some were simply about the way we organised our clinic. Another was that in the long term, creating a list of private ophthalmologists who would agree to care for our stable patients. But the main recommendation was a collaborative care model using either an optometrist or a specialist glaucoma nurse. And because of the distribution of our resources, our hospital actually favoured the nursing model, which would probably work better for some places and not for others. In the UK, the Royal College of Ophthalmologists has identified 3 ways nurses can viably participate in glaucoma care. The first is performing diagnostic assessments, but not interpreting the results, and this is more of a virtual clinic model. The second is that nurses would perform these same assessments, but manage patients following a treatment protocol. And the third is a more autonomous clinic where that treatment protocol is still followed, but that the nurse is a specialist and potentially a prescriber as well, so is less dependent on medical staff. Now, we've been heavily influenced by 2 hospitals who have been very kind to share their resources with us. The first is the Waikato Hospital in New Zealand and Musgrave Park Hospital in the UK, both of whom have nurse-led models. In New Zealand, the level of clinical skills performed by nurses is very impressive. And there are even some who are trained in YAG laser. So it's pretty amazing. At Musgrave Park, they have 3 types of glaucoma clinics. They've got a virtual assessment clinic, a collaborative care clinic with a specialist nurse or an optometrist, and then they've got their regular consulting clinic. So at Royal Perth, we have begun to expand the scope of practice for nurses by providing OCT training and training in other forms of diagnostic imaging as well. We would like to increase the skill set of our nursing team and help them become adept at glaucoma assessment in order to run a virtual type assessment clinic. And I'm hopefully going to begin some one-on-one training this year in order to learn some higher level clinical skills and become confident in actually assessing the optic disc properly. In the future, we could potentially implement a more shared care model, and eventually, it's my hope at least, that we could move into a more independent space if the need for that were established. Now, there are some barriers to achieving our goals. We need support and uptake from all teams within our department. Nursing staff have expressed reluctance to expand their scope of practice because they feel that participating in training will actually affect numbers on the floor and unfairly increase the workload of those who are not in the training program. So that's an issue that we're hoping to address. Will patients accept our new model? I'm pretty hopeful. From what I've read in the literature, patients seem to respond really well to the virtual clinic model. But I'd be interested to hear from the rest of the panel if they've experienced any reluctance from patients to give up that chair time with the ophthalmologist. And lastly, of course, having suitable resources is definitely essential. So this wouldn't be a PowerPoint presentation from a nurse without a quote from Florence Nightingale, but I do like this one because really at Royal Perth, what we're concerned about is creating solutions that are actually sustainable and work for our patients in the long term. Thank you very much.
Thank you very much for that, Lauren. We have a couple of questions, but I believe Drew would like to get the ball rolling with a question.
Thanks, May, and thank you to all the panelists, to Heather, Bernardo and Lauren for presentations. Yes, I'm going to start with a question around gender, because as most of you will be aware, Sunday was International Women's Day, and so IAPB, as well as focusing on glaucoma this week, are also focusing on gender. So my question to the panelists is, do you see more men or women presenting at your clinics? And do you need to consider gender when you're developing and designing your models?
So I might start on that since I'm female. And I would say that optometry is a very female-centric population. We've actually just swung to over 50% of optometrists within Australia are actually female. So within optometry, I think there is quite a strong representation, and a strong representation also on the management level. So when we look at the different associations, we've actually got a lot of women on the top level. So I think it is important to consider. I think there needs to be a really good balance. But I think that at the moment, we're not doing too badly in optometry.
So from the ophthalmology perspective, and it's definitely not as positive as the optometry one, unfortunately. The college has a, the College of Ophthalmology, that is, has a, it's put together a task force to get at least 35% of women in all sort of like senior positions within the college. And that's been happening for the past 3 or 4 years to get more in the community. When we talk within our microcosmos here, though, we have, and then, sorry, before I get into that, what Lauren also mentioned from the data from the 2016 data on ophthalmologists, about 60% were males, but they worked a lot more hours in average than the females. So essentially, there is a more of a male presence within ophthalmology, but a lot of our workforce is, getting close to retire. So we're looking into getting more female trainees into the program. But if we look into sort of like our glaucoma clinic here at the hospital, we have several senior female doctors. The head of unit is female, and I think we got a pretty fair representation of female in our hospital leadership.
From a nursing perspective, nursing, of course, is very female dominated, actually. So we are overrepresented there for sure. But I must say, as a nurse in the public health system in Australia, I feel quite well supported. I'm currently on maternity leave, and the standard is a year that you can return to your job, and you can actually apply for 2 further years without losing your permanent position. So that's one bright note. I do find that looking after women in public health seems to be going okay.
Okay, thank you for that. I think the question that Lauren asked at the end of the presentation was an interesting one. So I guess this is one for Dr. Suarez. So do patients accept non-medical practitioners? I guess that also applies to Heather in providing glaucoma care to members of the community in those joint clinics or independently.
So, thanks for addressing that, Kelly, actually, because it was a good point that Lauren raised. And Lauren, I did speak with one, I think it was an HMO, I'm not quite sure his name is Scott Sean, that actually wrote that paper. And but I'm familiar with the work you've done within Royal Perth Hospital and the glaucoma clinic. So I've had it with him over at glaucoma good for having the initiative over there. To answer the question now, we do ask all our patients that decline enrollment in the collaborative care program, which is about 25%. What is the reason why they're declining? And some of them will say because, for example, we offer an optometry practice which is on a neighboring suburb or not on their own, and they're more likely just to jump on a train and come centrally because the way the public transport is distributed radially, it's harder for them to travel horizontally, so to speak, to the next suburb within public transport. So a few patients do prefer to come in and not see someone which would, in terms of kilometers, would be a lot closer to them. But the top reason for declining enrollment in the program is lack of trust. They prefer to be seen by an ophthalmologist than by an optometry. In a way, we've actually started tackling that issue is by raising awareness of how they're actually more likely to be better looked after and not forgotten within the system if they enroll in the shared care model. So we're working together with Glaucoma Australia to actually educate the patients that is a viable and safe, if not safer, option for them.
Yeah, I was going to add, I think that education is really very key here because it's for a lot of patients that they do really like to know that they've seen the doctor and they feel that they've had then a really thorough examination. When in the monitoring clinic, there's not really any pushback because they're going to see a doctor at the end. But in private practice, generally speaking, the patients prefer to always have just at least that one appointment every year or one appointment every second year with the doctor. And I really think that education is where it comes down to it. With optometrists in Australia now being able to prescribe glaucoma medications, one of the reasons patients sometimes say they want to go back is to get a repeat prescription, but you know, they can get that from their GP, they can get it from an optometrist, and if they come to the optometrist, they can also get their pressure checked. And I think the more we sort of let patients know what can be done outside of the hospital, then I think that actually will reassure them. So as Bernardo was saying, I think all these education programs are really the way to go forward.
Okay, I think that also answers a question that one of the listeners had to how do we address the misconception that glaucoma is only about ophthalmology. Okay. Another question is, it's very inspiring to hear these models from Australia. Does anyone know an example of collaborative care from another country?
So as Laura mentioned, there's New Zealand has in specific areas. So that one was specifically for Hamilton, has also models of collaborative care. And where I train primarily in Brazil, there's also collaborative care models for patients should be followed up locally. The main, I think, take-home message is all those to have a worldwide approach. Every country has a slightly, if not very different health system. So obviously the collaborative care model needs to be adapted into that country. We've got a really big example, which is the Prasad Institute in Hyderabad in India as well, that has an excellent collaborative care model. But to have buy-in from all the stakeholders in the process, which is required for collaborative care, it needs to be very much aligned within what a specific health system can do in order to take that approach. So it's unlikely that a one-size-fits-all type of approach is going to be successful here.
Do you have anything?
I was just going to add. There's been quite a few in the UK. There's a number of collaborative care models in the UK, also in Scotland. There was a collaboration in Rotterdam where they actually had optometry-led clinics as well. So I think in most of the places where you get these collaborative care models, it's where there is an allied health professional who can actually take on some of that workload. So it really does depend, exactly as Bernardo was saying, as to what is available in each country and to what level then there is a comfort with nurses of taking on some of that role, or orthoptist or optometrist or whoever it actually is. But I think where it's successful, it's where there's a real good collegiate approach, where we have a number of different health professionals all coming to work together.
I think that's exactly right, Heather, because when I interviewed a clinical nurse specialist from Waikato, I was asking her, how does it work so well in your clinic? And she was saying it was that collegial trust that made all the difference.
That's great, thanks. There's also a question here from Fred Hollows Foundation Australia. So it says Fred Hollows Foundation Australia is also interested in the latest evidence of primary open-angle glaucoma laser treatments, which have also been delivered in community settings. Is anyone able to comment on that?
I can comment on it. So I think that is in reference with the somewhat recently published LIGHT trial, which compares essentially selective laser trabeculoplasty, which is laser with standard eye drop treatment. It is essentially, in summary, the paper says the laser is effective as a primary treatment, and it is probably cost effective as well if it works. It is cheaper than drops in the long run, but that does not remove the need of continuous care for that population. It gets rid of a few issues of compliance and all the topical medication side effects, but you still need to have established glaucoma care system to be able to follow up your patients.
Great, thank you. So that takes us to the end of the questions and answer session. Drew?
Thank you very much, May, and I'm sure that everybody listening online will join me in thanking both you and your panelists. We really hope that you have enjoyed this afternoon. Thank you for taking the time out to be part of Focus on Glaucoma. Do note that the conversations around glaucoma don't have to end this week. You can, of course, log into the IAPB website to access other webinars that are taking place this week, but also if you want to re-listen to any of the webinar from today or have a look at the presentations, they will all be available online in the next couple of weeks. And then keep in mind the IAPB Global Assembly 2020, which is being held here in Singapore, where I am this afternoon. It's being held here from the 12th to the 14th of October this year. It's a unique conference bringing together all eye care, and glaucoma is on the program. So for anyone who's really interested, we are calling for abstracts at the moment. The submission process is open, so please do get your abstracts in before the end of March. And for more information, have a look at GA2020 on the IAPB website. Once again, thank you to our panelists, to Heather, Bernardo and Lauren, and to Dr. Miho for coordinating this afternoon's session. It's great to have diversity in sessions. It's particularly great to have an ophthalmologist, an optometrist, and an eye nurse working together in a panel. So thank you all very much for your time, and thank you very much to all of the attendees. I look forward to seeing you all at some point on my travels around the region. Thanks very much.